So we've got some relevant clinical questions to go over at this point. We need to figure out how painful is this horse. So I like to classify the degree of pain because that kind of leads me down the path of how aggressive I need to be with sedation and analgesia in these cases. So mild, moderate, or severe pain. What drugs do we have to facilitate a safe and thorough colic exam, right? So in this case, we want to palpate the horse to see if we can come up with a better diagnosis than just colic. And we also want to pass a nasogastric tube to make sure there's no fluid buildup on the stomach, and we can also use that to administer some treatments. We have to be a little careful here, right? So on the premises, remember we're out on a farm. We're not in your vet school's hospital. So we don't have any stocks and we don't actually have any stalls on this premise. And the owner right now is the only one available to help restrain the horse for examination. So you don't have 2 techs with you and 5 students. So it's just you and the owner out in the field. So that does have to also affect your therapeutic choices, particularly when it comes to sedation. So aside from sedation, we also need analgesics for this horse, both during and after the exam, right? We want to provide the analgesia during the exam so that the horse doesn't try to go down and roll while we're either passing a tube or, even worse, performing a palpation. So let's go over some of these using the Pac-Man approach. All right, so P and A, our problem, it's colic, and I would classify these as moderate colic signs. The horse does have an elevated heart rate and respiratory rate and is showing multiple signs of colic, but he's not violently painful. So he's kind of down and rolling, but he's also pretty quiet in the meantime, and the owner was able to get him up and walk him to the barn. So that's our problem. Our approach right now is going to be medical, right? So we're going to use medical management for this. But remember, one of the most important determinants of whether or not a colic is medical or surgical is your response to initial sedation and analgesia, right? So if the drugs that we choose only last for 15 or 30 minutes, then that's going to make you wonder if maybe this is a more important surgical problem and it's not going to respond to medical management. So we're keeping that in mind, that these drugs, while they facilitate and treat the problem, they're also a bit of a diagnostic test. All right, so best evidence for colic. Unfortunately, you're not going to find any large-scale clinical trials that tell you how to treat medical colic or even surgical colic. And the reason that we don't have these, even though this is an extremely common problem and we've been dealing with it for years and years, is the underlying problems that cause colic are very diverse and the individual animals respond to them very differently, right? So I can't point you to a paper that says, hey, use these drugs and everything's going to be okay. But what we do know is that we need a cooperative patient. And so we do have drugs for that. And we also need to treat the pain during the examination. So we're going to start off talking about some of the drugs that can be used for these. And then once we narrow down the classes of drugs, we'll look at the evidence for which of those drugs might be the best in these cases. So remember, we do need a cooperative patient here. We can get nosebleeds or coughing with a nasogastric tube. So we need sedation and restraint. With the rectal, we're going to do one out in the field, which I think is becoming much more common, but we need to do it without causing any rectal tears or bleeding. So we need sedation and restraint, but we also have some drugs that will decrease rectal straining, which is going to greatly decrease your risk for rectal tears. I will say I don't do rectals or don't recommend doing rectals out in the field with every case. You're going to have to take this on a case-by-case basis. If it's a 2-year-old stallion worth $4 million, I'm not going to do that out in the field. If it's an old broodmare that has been palpated multiple times per year, every year for the last 10 years, you may not need to even sedate or give any of these drugs as well. So take this on an individual case basis. Same thing with passing a nasogastric tube. Some horses tolerate it fairly well, other horses absolutely do not. And then analgesia, we need to prevent movement and rolling during the exam. And we always have to keep in mind our safety when we're doing this out in the field. So these drugs will help keep us safe as the veterinarian as well. So we can start kind of looking at some review papers maybe that will go over some of the classes of sedatives and tranquilizers, drugs we use for chemical restraint. So we can start kind of looking at some review papers maybe that will go over some of the classes of sedatives and tranquilizers, drugs we use for chemical restraint, and then analgesics. So you may know these already, but if you don't, or if you want to get some new ideas, you can look up at some of these papers. And what we'll find when we go through those papers is that we can come up with some classes of drugs, most of which are classified based on their mechanism of action. So if we look at sedatives and tranquilizers, alpha-2 adrenergic agonist drugs are very commonly used in the horse, right? So their mechanism of action is the same as their class of drugs, right? They're alpha-2 adrenergic agonist drugs. And I want to encourage you to always, when someone out in the clinics asks you, well, what's the mechanism of action of xylazine, that you say alpha-2 adrenergic agonist. This is because most students, I find, remember, oh, it's an alpha-2. And then you ask, well, agonist or antagonist, and they almost always go to antagonist, right? Because these cause CNS depression, and students associate that in their mind with inhibition, but that's not true. So agonist action at the alpha-2 receptor in the CNS causes sedation. So these are agonist drugs. We have 3 drugs labeled for use in the horse: xylazine, romifidine, and detomidine, and they all have their benefits and uses in these cases. So we'll go over the individual drugs a little later. Other sedatives or tranquilizers in horses, you'll read about phenothiazine tranquilizers, which are dopamine type 2 receptor antagonists like acepromazine, and also benzodiazepines, which are GABA agonists like Valium, diazepam, or midazolam is also used in the horse. We're not going to talk about these any further. I did want to list these just to be complete, but acepromazine is, yes, it's a tranquilizer, but in and of itself, it doesn't have any analgesic effects, and it also can cause some dilation, vasodilation and hypotension at higher doses, and we typically want to avoid that in these cases. The benzodiazepines certainly will cause sedation, but in a standing horse will also cause pretty severe ataxia. So their use is typically reserved in as pre-anesthetics or when we actually want to lay the horse down. So if we look at drugs to treat rectal straining, or decrease rectal straining, we've got 2 basic options. One is the local anesthetics, which work through sodium channel blockade and decrease nerve conduction. And of those, lidocaine is used most commonly, and we don't give it systemically for this. We actually give it per rectum, right? So it has a topical effect on the rectum, so you can drop some lidocaine, and we usually drop about 20 cc's, dilute it to 60 cc's with water or saline, and put it in the rectum and give it a couple of minutes, and it will decrease rectal peristalsis. So this can be very useful for your rectal examinations. Anticholinergic drugs, which are also called parasympatholytic drugs, block acetylcholine and can actually decrease GI contractions. So we have atropine and N-butylscopolamonium bromide, which is basically called Buscopan in the equine world because that's the labeled product that we have for horses. If you're treating a colic, Buscopan is used almost exclusively because atropine has a very long-lasting effect. And the benefit and disadvantage of Buscopan, and we'll go over a few more later, but when we're talking about the rectal straining, is that it decreases rectal straining, but it also has more global effects than the lidocaine, so it's going to decrease GI peristalsis throughout the entire GI tract, whereas the lidocaine has more of a local effect. But by decreasing GI peristalsis throughout the GI tract, you're also getting an analgesic effect. So other analgesics we can talk about in the horse are opioids. So when we look for analgesic effects, typically we're talking about mu or kappa receptor agonist. Mu receptor agonists like morphine or partial agonists like buprenorphine tend to be thought of as better for pain, but they also in the horse have increased risk for adverse effects like CNS excitement and GI ileus. So they're not used for this very often. We do have butorphanol, which is a kappa receptor agonist, mu antagonist, or sometimes we do have butorphanol, which is a kappa receptor agonist, mu antagonist, or sometimes referred to as a mu partial agonist. It is labeled for use in the horse, and it has decreased risk for adverse effects compared to those other two drugs. So butorphanol is the one most commonly used for colic. NSAIDs, of course, have anti-inflammatory and analgesic effects and work through cyclooxygenase inhibition. We do have multiple NSAIDs labeled for use in the horse. There's really no reason to go off-label with any of these drugs. So flunixin meglumine or banamine, phenylbutazone or bute, firacoxib, which is Equiox, and ketoprofen, which is ketofen, are all labeled for use in the horse. We'll go over choices of those in a bit. We'll cross ketoprofen off. It is sometimes used, if I use it for colic, it's typically in foals because it has fewer adverse effects in foals, but it's rarely used in adult horses. And then we have non-COX inhibiting NSAIDs, which are centrally acting drugs that have effects on multiple systems, including serotonin and cannabinoid receptors. And some of these drugs also have antispasmodic effects through calcium regulation, and the drug in that class is dipyrone. Dipyrone has recently been labeled for use in horses in the US. It's labeled as a treatment for fever because it's an excellent antipyretic, but because it has this antispasmodic effect, its use for colic will probably be increasing over the next couple of years. When I was a child, a very long time ago, we had dipyrone around and used it very frequently for colic in horses, and it has a decreased risk for adverse effects compared to some of the other NSAIDs, and is pretty effective for spasmodic or impaction colics. So look for that by the time you guys graduate to be in common use. So as we've gone through this kind of exercise, we've talked about drugs for sedation, drugs for analgesia, and drugs to modify motility, particularly in the rectum, but somewhat in the rest of the GI tract. So if you're looking at treating these animals out in the field and want to decrease drug use, you want to pick drugs that have multiple uses, right? So alpha-2s cause sedation, but they also cause analgesia. Dipyrone is an analgesic as well as a motility modifier, as an antispasmodic. And anticholinergics like Buscopan will facilitate rectal exams and also have an analgesic effect via the antispasmodic uses. So we would choose drugs within those classes, and we're almost always going to give an NSAID, and opioids in my mind are kind of a case-by-case basis. So Now that we've gone over the classes and their mechanisms, let's look at the absorption, administration, adverse effects, and monitoring for problems. So the classes we'll narrow it down to for this are the alpha-2 agonists, the opioids, anticholinergics, and the NSAIDs. So if we look at the alpha-2s, like I said, we have 3 labeled for use in the horse: xylazine, romifidine, and detomidine. And they do have a lot of differences within the drug class. So xylazine is the one that I consider to start working the fastest, which is good, right? We want fast sedation and analgesia in these cases, but it also lasts the least amount of time. So sedation and analgesia are fairly short duration. Romifidine's kind of in the middle, but it does take the longest to work. So most people don't use romifidine for acute colic cases for this reason. It takes 5 to 10 minutes for maximal effect, even when it's given IV. So it's not typically used because we want rapid onset of action. Detomidine is somewhere in between xylazine and romifidine for onset of action, but it does have the longest duration sedation and analgesia. And so especially when you're a new vet out there in the field, your rectal exams and passing a nasogastric tube are going to take you a little bit longer than when you've been practicing for 20 years. So choosing detomidine in those cases for that reason, I think, is justified. If we look at the last column on the table, this is specificity of these drugs for alpha-2 receptors versus alpha-1 receptors. And you can see xylazine is the least specific for alpha-2, which means that it has more of an effect on alpha-1. So alpha-1 receptors, remember, are related to things like vascular effects. So xylazine may cause more adverse effects than, say, detomidine, even though it has more potent sedation and analgesia. Romifidine is the most specific, but again, it's rarely used for treatment of colic. Adverse effects that we worry about with these drugs are ataxia, and a lot of that has to do with specificity. So romifidine causes the least ataxia, detomidine second least, and xylazine the most. Decreased GI motility, but this is typically very segmental, so proximal duodenal motility may be decreased, and it is short-lived, so not really a problem in colic cases. Cardiovascular depression and AV block can occur. So this class of drugs is known to cause arrhythmias, and the most common one is the second-degree AV block. Typically, this does not cause a problem in a horse unless they already have underlying cardiovascular compromise or arrhythmias present. So if you give these drugs to a horse that already has an AV block, typically those horses will have low heart rates, so down around 24 beats per minute. I have had horses go down to 8 beats per minute with their heart rate after giving doses of either xylazine or detomidine, and they do have a tendency to pass out when their heart rate is that low. So you always want to make sure before we administer alpha-2 agonists that you've taken a good listen to the heart and made sure that everything is okay there. Choosing between xylazine and detomidine for colic somewhat depends on the degree of pain. So for mild cases, xylazine will probably last long. Choosing between xylazine and detomidine for colic somewhat depends on the degree of pain. So for mild cases, xylazine will probably last longer. For moderate to severe, I tend to go more with detomidine. And if I'm trying to do a rectal out in the field, I tend to either steer clear of xylazine or only use it if I'm combining it with butorphanol. So I always say xylazine slows down the front end but speeds up the hind end. And if you look at the label for this, in spite of sedation, the practitioner and handler should proceed with caution since defects reactions may not be diminished. So if you go to rectal a horse that's just on xylazine, he can still definitely kick you even if he looks very sedate. in the front end. So again, I tend to choose detomidine if I'm going to do a rectal, or I'll combine xylazine with butorphanol, which is going to have a synergistic effect on sedation and analgesia as well. And you're less likely to get kicked, which again is always our goal. Detomidine, we have a couple formulations labeled for use in the horse. One is an injectable, one is a transmucosal gel, and hopefully all of you would know that when we're giving these drugs, we want to go IV because we want a rapid effect. And we would not want to use the transmucosal gel, right? If you look at the pharmacokinetics of these, the gel actually takes 30 to 45 minutes to reach maximum concentration and have a sedative effect. So the gel is really only for, say you've got the farrier coming and you have a horse that doesn't like to have his feet touched. You can give the gel 30 to 45 minutes before the farrier shows up. And then the horse will be nice and sedate by the time he gets there. With IM administration, it still takes quite a while and you don't get concentrations nearly as high as with IV. So we're going to choose the IV injectable formulation. Here are some evidence-based medicine for alpha-2 agonists if you want to read up a little bit more on those. Always have some reversal agents on hand. If you're a small animal oriented, you probably are used to reversing alpha-2 agonists on a regular basis. We're probably not going to do this in any of our colic cases unless the horse has a pretty severe adverse reaction to the alpha-2 agonist. But we do have doses available, and it's not a bad idea to have a bottle of these on your truck just in case. But then if you look at the literature, you might find this paper. It's actually proceedings from the AAP. Review of fatalities and adverse reactions after administration of alpha-2 adrenergic agonist reversal agents in the horse, right? So that's a little scary. So it's another reason why we wouldn't automatically reverse these drugs in horses. We don't really know why this occurred. It is an interesting article, though, if you wanted to read up on that. But we also don't want to reverse these drugs because we're using them for their analgesic effect as well. And we want that to last as long as possible. Opioids, again, butorphanol is the one we're probably going to use. It can cause some CNS excitement given alone in horses without concurrent use of either an alpha-2 or a phenothiazine. But in foals, it's a nice sedative, has a nice sedative effect. So it's a very good sedative analgesic in foals. Again, I like to combine it with xylazine to reduce kicking. If I'm using detomidine to begin with, typically I won't reach for the butorphanol unless we're dealing with more severe pain. It can decrease GI motility, but compared to morphine and buprenorphine, there's little clinical significance associated with this drug, probably, again, because it works more at the kappa receptor. Cardiovascular depression, I've never seen that with butorphanol, so you'd have to get really high doses in there in order for that to have an effect. And the higher the dose, the more profound and the longer lasting the analgesia. So typically when we're giving this for colic, we're looking more at the 10 to 20 milligrams per 500 kilogram horse range. Again, it's been studied quite a bit, and so there are some references for you if you want to read up on them. Again, it's been studied quite a bit, and so there are some references for you if you want to read up on them. The anticholinergics, so again, buscopan is the drug that is FDA approved for use, and it's actually approved as a treatment for spasmolytic colic in the horse. The use in facilitating a rectal examination is off-label, but it's pretty widespread. And the good thing about its effects on rectal straining is that it will occur at lower doses than what's on the label. So you can give a half dose of buscopan and get through your rectal examination with little straining and not have as many adverse effects. It's only labeled for single dose administration, so if you're going to be doing a lot of repeat rectals, at a half dose, I usually don't recommend giving it more than twice within a 12-hour period. One thing you do need to know about Buscopan is that after you give it, again, it's an anticholinergic, it's going to cause tachycardia, and this can be actually pretty profound. So 60, 70, 80 beats per minute. It's short lasting, so should only last about 30 minutes after administration. But you need to know what the horse's heart rate is before you give either an alpha 2, which will decrease the heart rate falsely, or Buscopan, which will increase it falsely, right? And heart rate is one of our measures of pain, so we want to make sure that we have that all together before we start. And there are some concerns about combining alpha 2 agonists with anticholinergic drugs. So this was a paper that looked at arrhythmias developing, and so there is concern about sustained ventricular tachycardia after co-administration of xylazine and Buscopan. So you can see the heart rate goes up with Buscopan, with or without xylazine. Blood pressure goes up, but some of those horses did develop ventricular tachycardia. So if you are using Buscopan as a treatment or to facilitate your rectal exam, what I typically would try to do would be to just twitch the horse during the rectal without administering a further sedative. And some horses may be amenable to that, some won't. You may want to use detomidine instead of xylazine. We don't actually know, we don't have any similar studies looking at combined Buscopan and detomidine, but it actually induces typically fewer arrhythmias than xylazine altogether. There are some studies out there comparing Buscopan to lidocaine for rectal examination, and it does have a better effect, but again, it has a more global effect. And then looking at experimental models of colic, Buscopan produced better analgesia than butorphanol alone. So you can take that into account. It is a good drug. It does work. It is effective in certain cases, but I always like to evaluate each case individually because of the adverse effects that are associated with Buscopan. And I have had it actually make colic worse, particularly if it's an early surgical lesion of the small intestine. You give Buscopan, GI motility stops, and potentially prolonged ileus or nasogastric reflux will occur. So use it, but use it cautiously. And in a lot of the other countries where Buscopan is labeled for use in the horse, it comes combined with dipyrone. And so those two together can have a beneficial effect. All right, NSAIDs, we'll talk about flunixin first because it is most commonly used for colic, and it's generally considered superior for treatment and prevention of visceral pain and endotoxemia. And that's fine if you want to have Banamine as your go-to NSAID for treatment of colic out in the field. I think that's perfectly reasonable. You'll hear about the different dosing regimens for flunixin. The low dose is not very analgesic but does have some anti-inflammatory effects, but you're not going to use that dose for colic. In the hospital, sometimes we'll give half dose, so 0.5 mg per kg, as kind of a way to monitor response to pain medications. But in most cases out in the field, you're going to be giving the full label dose, which is 1.1 mg per kg. You're going to want to give it IV if you're out there, just to have the most rapid onset of effect. And also remember, when we're dealing with colic, we're dealing with issues in the GI tract. So oral absorption may be affected. But the high dose is going to have the most anti-inflammatory, analgesic, and antipyretic effects if those are present, if fever is present. But it does also have the highest risk for adverse effects. And there is some concern about masking surgical colic pain. In my experience, this isn't an issue. If you've got maybe a right dorsal displacement or a left dorsal displacement of the large colon, it may mask and push back surgery for a little bit, but you've got your other diagnostic aids to help you determine those. If you have a horse with a strangulating obstruction, Banamine is not going to mask surgical pain or delay time to surgical referral. Phenylbutazone is most commonly used for lameness and musculoskeletal pain in horses, but it can actually be used for colic. It is inferior to flunixin for treatment or prevention of endotoxemia, but it does have some prokinetic effects. So it actually may speed up the GI tract, which may be beneficial in colic cases. If I am treating a horse and I have flunixin and phenylbutazone right next to each other, I'm going to pick flunixin for colic. But if I'm 3 hours away from the farm and a horse is actively colicking and all the owner has on the farm is phenylbutazone, I would say have them give the phenylbutazone and give that horse some pain relief while you're on your way out there. It is the most ulcerogenic. So we do have to keep that in mind, but for a single dose, I'm not terribly worried about that. Firocoxib is also labeled for use in the horse, and we now have an IV formulation. The benefit of firocoxib is that it is a COX-2 specific inhibitor, very specific, very selective in the horse. So it can be used with potentially a decreased risk for adverse effects. But it's also not considered as potent an analgesic as flunixin or phenylbutazone. It can still have issues with the kidneys and potentially with coagulation. So we do have some concerns about that. But if you had a horse that has reacted unfavorably to flunixin or phenylbutazone prior to this episode, you may want to use firocoxib because it may be a little safer. We did do a clinical trial comparing firocoxib to flunixin in cases of strangulating obstruction, and there was really no difference in analgesic effects by 12 hours after surgery. But there are some caveats to that in that the horses had already received flunixin in the field, and we did use a loading dose of firocoxib. So you guys have talked about loading doses before. Firocoxib actually takes about, with IV use, it's a little less of a problem. But it requires accumulation in the blood in order to reach therapeutic concentrations. So typically, you're looking at several days for maximum effect, and we don't have that with colic. So we give 3 times the loading dose in this study, and it seemed to be fairly effective. And actually, we had less endotoxin absorption from the GI tract with firocoxib compared to flunixin. I'm not sure that really applies in this case here because, we're not dealing with a small intestinal strangulating obstruction, and endotoxin absorption should be fairly minimal. Adverse effects of NSAIDs, oral, gastric, and colon ulceration, and then renal disease are most common what we worry about. In this case, I'm not terribly worried though, right? So only a single dose is being given at this time. If we were to have a horse that is chronically on an NSAID, redosing with an NSAID, then we might start to worry about it more. But with this case, the horse doesn't seem to be terribly dehydrated, maybe a little bit, but we're probably going to give him some fluids, so it's not much of an issue. So these are more chronic use or overdose adverse effects. What we do have to worry about is injection site reactions. And so this is going to guide how we give these drugs. So phenylbutazone is very irritating if given outside of the vein, and can actually cause severe tissue necrosis. So this was a horse that got phenylbutazone outside of the vein and sloughed part of his neck. And actually, if you look close, you can see multiple very important structures just hanging out there in the open, right? So it was given on the left side of the neck, so we do have to worry about the esophagus being there and the left recurrent laryngeal nerve, the vagosympathetic trunk. But we could also actually count this horse's pulse by watching his carotid pulsate through the giant hole in his neck. So it can be very scary, and I don't recommend that owners give IV phenylbutazone unless they are very good at it. Flunixin can have just as many problems if it's given IM, right? So abscessation, pain and swelling. So this horse got it in the gluteals and actually developed a very severe abscess that actually went in and prevented him from passing manure, right? So it got so big that it actually compressed the rectum. And that was the reason this horse was actually colicking. The other thing, and the very serious thing we worry about, is clostridial myositis, right? So if you give IM flunixin meglumine, it causes tissue necrosis, which sets up an anaerobic environment, which activates clostridial spores that are already in the muscle. And then it can set up an infection where the only option you have to save the horse's life is to get air to the tissues, which means you have to slice them open. This is very disconcerting for the owners and can be fatal for the horse. I always stress this disease because flunixin is labeled for IM use in the horse. It's a very old label. They didn't know as much back when it was initially approved. You as the veterinarian need to know that IM use is not acceptable and make sure that your owners don't actually use this drug IM. So all these adverse effects are increased in horses that are off feed or dehydrated. So we have to worry about them a little bit in colic horses, especially if we're going to go beyond that initial dose. We don't want to co-administer these drugs. So if you told the owner to give some bute because you'd be 3 hours away, when you get there, unless you don't have any other choice and know you're not going to be able to get back out, you wouldn't add Banamine or Firocoxib to that regimen if the horse has already gotten it. If you're giving it, you're going to give it IV. If the owner's administering it, have them give it orally. And the good thing about if all they have on the farm is phenylbutazone or flunixin injection, you can take that injection and give the same dose orally, and it is absorbed. In a normal horse anyway. In a horse with colic and GI issues, then maybe not, but it's better than nothing. So those are the classes. I did want to put a plug in here for drug labels. So like I said, there's not a lot of clinical trials out there saying this is the way we need to treat horses with colic. But all of the drugs that we talked about, for the most part, are labeled for use in the horse. And so they have package inserts, and really use those package inserts. They have great information on there about pharmacokinetics, pharmacodynamics, adverse effects, and dosing. And if you don't want to keep all those little bits of paper that come with the drug around, these are some websites where you can find that information as well. In particular, I'll put a plug in for VetGram because I work for FARAD. If you are a food animal vet, go ahead and get used to using that site. So what happened with Red? He was sedated with ditomidine at 10 milligrams per 500 kilograms. He was twitched, and we used topical lidocaine to do a palpation per rectum and felt a large, medium, firm pelvic flexure impaction. passed a nasogastric tube. At that time, didn't get any reflux, and administered fluids and mineral oil, and dosed him with Flunix and meglumine at the full dose, the 1.1 milligrams per kilogram IV. He was held off feed overnight and treated with one more dose of flunixin and oil and water in the morning. Began passing manure overnight. The oil showed up after the second dose in the morning. So he was initiated feeding with mashes and grass throughout the day and was back to normal within 48 hours. So if at any time, even after this class, you guys have questions, feel free to email me at jdavis4@vt.edu. Thanks.